month lunch and learn series. So during your lunch hour, you can come and learn a little bit more about how to diagnose and treat HIV. One of the biggest problems with HIV that we face in the 21st century is co-infection with hepatitis C. And in fact, deaths from hepatitis C are probably the leading cause of death in people with HIV infection. That's the bad news. The good news is that we are in the middle of a revolution in terms of treatment of hepatitis C therapy. And things are evolving very quickly, and for those of you who remember the 90s with HIV care, it's actually evolving much faster than it did even then. And so we not only have drugs that we can use to treat hepatitis C, we can cure it. We can cure it in as little as 12 weeks. There are new generations of drugs which are coming out, which are getting better and better, less toxicity, less pill burden, and all of the good things that we associated with this. And so the person giving the talk today is Dr. Natanya Utay. Dr. Utay is faculty here at UTMB. She is a graduate of Baylor, right? Baylor College of Medicine, right? Not the football guys, okay? All right, Baylor College of Medicine. She then went to University of Washington, did a residency, and then did a really long fellowship at the National Institutes of Health, and then decided she needed to get warm and came back to Texas. So Dr. Utay is really an expert in hepatitis C. She manages our HIV-HCV program. She also is doing a lot of research in regards to inflammation and hepatitis C. And if there's anybody you need to go to, this is the go-to person when it comes to hepatitis C in this area. And so without any further ado, I'll let her tell you all about it.
Thank you, Phil. I think when I aimed to warm up, I overshot. But in any case, a little toasty today. Thank you all for coming, and thank you for tuning in remotely. The objectives today are to explain how the new direct-acting antivirals work for hepatitis C treatment, to describe the regimens that are currently recommended for hepatitis C, and I'll really focus on the genotypes that we see most often in the U.S., and to discuss some of the side effects and drug interactions, and specifically focus to some extent on the drug interactions with antiretrovirals. So hepatitis C virus was isolated and defined in 1989. There's 6 main genotypes, 3 that are pretty common that are most common in the U.S. It actually can survive outside the body for up to 4 days. I've seen people for needle stick injuries when a needle's been outside the body or has been laying around for a couple of days. That still potentially could be infectious depending on the amount of blood present. It's highly error prone, so much like HIV, it requires multiple drugs to avoid developing resistance to any single drug. So there are about 170 million people worldwide infected with hepatitis C infection. 4 to 5 million or so are co-infected with HIV, and about 350,000 people die annually worldwide. In the U.S., it's estimated there are about 3 million people or so infected, and 400,000 in Texas. And actually, there's about 5,000 people a year are diagnosed in Houston with hepatitis C. I don't know about Galveston, but that kind of gives you an idea for the general geographic area. Interestingly, most people don't know that they're infected. They were born between 1945 and 1965, acquired hepatitis C, maybe one-time experimental drug use in the 70s and 80s, maybe blood transfusion, but a lot of people don't know they have it, and so we're really pushing for screening in this population. It's currently the leading cause of liver transplantation in the U.S., and there are about 15,000 deaths annually in the U.S. attributed directly to hepatitis C. So risk factors, I mentioned people born between 1945 and 1965, and that's something I've been really working with our internal medicine faculty and residents here and pushing people to get screened. Current and former injection drug users, it is spread parenterally through the bloodstream or potentially sexual activity. Iatrogenic transmission, actually back in the day when they reused vials, reused needles more often, this was potentially a mode of transmission. Chronic hemodialysis patients are also at risk, and people who received blood transfusions before they started screening in 1992. Estimated transmission rate of hepatitis C now is about 1 in 1.4 million transfusions. So still possible, but very, very low risk. There's about a 4% mother-to-child transmission rate. It is not transmitted through breast milk, but can be transmitted from the mother to the baby, and this was really important. That's one reason, and I'm not really touching on this in the future, but one reason why these drugs are particularly important, because in the interferon ribavirin era, those drugs were contraindicated in pregnancy. So there's really no way to prevent mother-to-child transmission. People with HIV infection, because they share some of the similar risk factors, are at risk for hepatitis C infection. And sexual intercourse, for a long time, it wasn't thought that this could be transmitted sexually, but actually, primarily, men who have sex with men are at risk for acquiring hepatitis C infection. We have seen several cases in our clinic of sexually acquired hepatitis C infection. So in the U.S., the majority of hepatitis C infection is genotype 1, and of that, it's primarily genotype 1A, about 2/3 1A, 1/3 1B. This is important because it will influence the treatment regimens. About 17% are genotype 2 and 10% are genotype 3. And what's interesting about genotype 3, it causes slightly different morphological changes. It causes more fat deposition in the liver, which is something of research interest and potentially and certainly of clinical interest as well. So acute hepatitis C infection is actually usually asymptomatic. It might be picked up through routine liver enzyme tests, or someone who comes in for STD screening and the clinician is astute and orders the hepatitis C RNA or antibody, as well as the gonorrhea, chlamydia, etc. test. But usually it's asymptomatic. 80% or so of people will not have symptoms. When they do have symptoms, it's usually about 6 weeks or so after exposure, and they'll have some fatigue, some nausea, vomiting. Sometimes they can have some jaundice as well, sometimes joint pain. But generally speaking, it's asymptomatic. About 20% of people will clear the virus spontaneously, although this rate is a little lower in HIV-infected people. So the natural history of the 80% who develop persistent hepatitis C infection, about 10%, somewhere in the 5 to 20% range, will develop cirrhosis. And certainly in the TDC system, we see a huge number of people with cirrhosis. And of those, about a quarter will actually progress to developing end-stage liver disease that would, people who actually would need a transplant for survival, or hepatocellular carcinoma. And the rest kind of have the slowly progressive process and perhaps succumb to something else before they develop hepatocellular carcinoma. But you can see of, say, 100 people who are infected, 8 are going to develop cirrhosis and 2 are actually going to develop severe consequences of hepatitis C. Now, how do we know whether they've resolved infection? Well, the primary screening test for hepatitis C is an antibody test. So anyone who's been infected with hepatitis C, whether they clear it or have persistent infection, is going to have a positive antibody test. People who've cleared the infection are not going to have detectable hepatitis C RNA levels, whereas people with chronic infection will have hepatitis C RNA levels. And this is confusing. Actually, one of the infectious disease fellows was reprimanded, maybe, might be a strong word, but essentially for calling someone chronic hepatitis C without having the clear documentation of the detectable hepatitis C RNA levels. So this is important for really saying that someone has chronic hepatitis C infection instead of cleared hepatitis C. So who should be treated? This is the American Association for the Study of Liver Diseases and the Infectious Disease Society of America joint guidelines. Treatment is recommended for all patients with chronic hepatitis C infection, the only exclusion being people who have short life expectancies, whose life expectancies would not be improved by hepatitis C treatment or transplant or other direct therapies. So in general, so essentially the guidelines, the lead experts in the field are recommending treatment for everyone. Now, one of the barriers that we've run into is coverage by insurance companies, Medicaid, and so forth. And that Texas Medicaid and a lot of state Medicaids are actually only covering people with severe fibrosis or cirrhosis. And actually, there is a recent lawsuit in Washington State because Washington State was one of those states that was only covering people with advanced fibrosis and cirrhosis, and the judge actually ruled in favor of the plaintiff, and Washington State is now being compelled to treat everybody, although they've been a little obstinate in going through with that. But in any case, I'll explain why that's such an ordeal or such an issue in a little bit. In terms of pre-treatment assessment, it's recommended that everyone get a liver biopsy or some non-invasive evaluation of the degree of hepatic fibrosis. There are some imaging techniques, ultrasound, fibroscan, as well as some calculations that we can do a variety of laboratory values, everything from AST to platelet ratio index to more complicated values like mp4 and fibro tests that we can send away. So why do we want to treat people? Well, obviously there's a chronic infection. People don't like having a chronic infection. Some people feel like they're lepers and don't want to interact with other people, but it actually has a substantial impact on mortality. So this is a study of about 530 people, and this was in the interferon era, but 530 people who were followed for 13 years, and they looked overall at the 10-year cumulative incidence of mortality. And all-cause mortality among people who achieved a sustained virologic response, which essentially is what people used for long-term instead of using the word cure, because they were a little reluctant to use the word cure. But what that means is undetectable HIV or hepatitis C RNA levels at least 12 to 24 weeks after treatment. So you can see people who had undetectable Hep C RNA levels had about a 9% 10-year mortality compared to 26% of people who did not achieve cure. So this certainly points to the mortality benefit. And in terms of specific causes, liver-related mortality only occurred in about 2% of people who were cured as opposed to 27% of people who were not. So certainly there is a benefit for cure. So interferon ribavirin was for the longest time the treatment of choice and the only available treatment for hepatitis C infection. And this is percent failure rate. And you can see, looking at all hepatitis C infected people who were treated, 48% of people would fail. So essentially 52% of people who went through this 48-week painful course of feeling like they had the flu, anemia, some people had psychotic breaks and just feeling terrible for an entire year. Of those people, only 52% actually got cured. And if you zoom in and look at genotype 1, it was a little worse, 56% failure rate. If you look here at HIV, hepatitis C co-infection, 60% failure rate, so about a 40% response. And of those, people who were co-infected with genotype 1 had upwards of an 80% failure rate. And so add that to the fact that a lot of our HIV patients, unfortunately, have issues with either anemia or psychiatric manifestation or psychiatric problems, which would render interferon unsafe to use. Really, there wasn't a good option for our co-infected patients. So scientists have, over the years, worked out the life cycle of hepatitis C infection, and this has really led to the development of these new interventions. And you can see here, hepatitis C will bind to its receptor, CD81 for anyone who's interested, on the hepatocyte cell membrane. So essentially, these are the main cells, the liver cells that get infected. The virus is uncoated, and you get the hepatitis C RNA. Now, this RNA can go two places. One, it can go to the endoplasmic reticulum, which is going to translate the RNA into a polyprotein. So much like HIV, when the RNA is translated into a protein, it's made into this big, long protein called a polyprotein that then has to be cut into segments to form functional proteins. So hepatitis C does the same thing. The RNA can also go to the nucleus where it can be reproduced, and then together with the proteins that then get cleaved, the RNA and the proteins combine, make this virion or viral particle, and then are transported to the surface of the cell and released. So this led to the development of several inhibitors. Now the protease, so they're protease inhibitors, much like for HIV. So these protease inhibitors block the protease that cleaves that polyprotein into the individual proteins. So this is one portion of the virion that cannot assemble. And these are called NS3-4s, the name of the protein on hepatitis C that defines the protease inhibitor. There also are polymerase inhibitors. So much like we have reverse transcriptase inhibitor, they're nucleotide reverse transcriptase inhibitor, and non-nucleoside reverse transcriptase inhibitors. They're polymerase inhibitors that are nucleotide or nucleoside or non-nucleotide polymerase inhibitors that inhibit RNA replication. And then we don't really have a comparable FDA-approved drug, HIV drug here, but there is they have identified inhibitors for this NS5A protein that's thought to be involved in virion assembly and release of the virus particle from the hepatocyte. So these are essentially the three areas that have been targeted with the new medications. Now, unfortunately, the people who are naming these drugs took a lesson from the myriad of HIV medications and the difficulty that many people had in keeping the different classes of HIV medications straight, that they actually gave the similar classes the same suffix. So you can actually remember what the drugs do. So the protease inhibitors, Previr, the NS5A inhibitors up here, NN-Asvir, so A-Asvir, and the NS5B inhibitors, NN-Buvir. So at least, when you're looking at medications and, when you're thinking about how these might fit into the life cycle, you can deduce just from the generic name what exactly the drug is doing. And feel free to interrupt, by the way. So these are the currently FDA-approved regimens. And this is, I try not to use brand names too often, but these are the ones you're going to see advertised on TV, in magazines, the ones your patients are going to ask you about. Sovaldi was the first one that was FDA approved. This is sofosbuvir and Olysio, actually. These were the two that were first FDA approved, Cimeprevir. And then came along Harvoni, or Harvoni, depending on who you ask. The drug rep said they liked the idea of Harvoni rhyming with harmony. So that's what I use, but people have different approaches. So this is a combination of ladipasvir, sofosbuvir. Vicura, and I'll go into all of these drugs, is actually a combination of 3 different drugs with a ritonavir booster, so much like protease inhibitors for HIV infection. Paritaprevir requires ritonavir. And then there's Declinza and Zepadier. So Declinza is decladisvir, and Zepadier is this elbasvir, grazoprevir. These are the 2 most recently approved medications. So how do we choose which of these regimens to use? Well, probably the most important factors that we use first are genotype, and 2, actually the presence of cirrhosis. Also, prior treatment failure. The hep C RNA level can sometimes determine which regimens or what the duration, optimal duration would be. For some medications, resistance mutations can be a factor. There can be acquired resistance, where a virus that is acquired can come already with some, particularly protease inhibitor resistance. Comorbidities actually make a big impact, particularly cardiovascular disease and renal disease, and deciding which regimens to use. Drug-drug interactions certainly make a major impact. And lastly, insurance funding, or whatever kind of funding that the patient has. So this is a big summary slide, something that I will probably print out and put on my wall. I have something similar on my wall. But what you can see from these regimens, a couple of patterns. So these are sofosbuvir ribavirin, sofosbuvir cimeprevir, sofosbuvir lodipasvir, essentially the currently approved regimens. And you can see that genotypes 1 and 4 tend to go together, and genotypes 2 and 3 tend to go together as far as which regimens are efficacious. I wish I knew exactly why that is, but essentially that's how I decided to break up this talk too, and to talk about, rather than a numerical order 1, 2, 3, 4, I'm going to talk about genotypes 1 and 4 first, because they're going to use the same regimens essentially, and then I'll talk about genotypes 2 and 3. So first I want to focus on what we see most commonly, and that's people with genotype 1A and no cirrhosis. And there are 5 different regimens that are possible, that are recommended. Most of these are 12 weeks. The only one that actually requires ribavirin is this complicated regimen, the paritaprevir, ritonavir, and bedivir, just abivir regimen. But otherwise, generally speaking, 12 weeks is sufficient for genotype 1A without cirrhosis. And actually for genotype 1B without cirrhosis, 12 weeks is sufficient as well. When people develop cirrhosis, sometimes they require longer treatment and or the addition of ribavirin for achieving cure. So cimeprevir sofosbuvir was the first combination that was FDA approved for treating hepatitis C infection. And I put down here essentially some of the how the medications are to be taken. These are both once daily without This Semipravir has to be taken with food, sofosbuvir without food. And this is why funders are reluctant to treat everybody. So $22,000 for a 4-week supply for Semipravir, $28,000 for a 4-week supply for sofosbuvir. So you're talking $50,000 for 4 weeks, and the recommended treatment duration is generally 12 weeks for most, in most cases, 24 weeks for a lot of people with cirrhosis. You're talking $150,000 to $300,000 to treat someone. But in any case, it was very successful. You can see that there's, so again, I'll talk about sustained virologic response, which is undetectable hepatitis C RNA. And most of these studies have really looked at the undetectable hepatitis C RNA levels after 12 weeks after completing treatment. And you can see here 96, 97% cure rates with 12 weeks of Semipravir, sofosbuvir treatment for genotype 1, and genotype 1A specifically, non-cirrhotics. Now, if we look at adverse events, they're actually pretty well tolerated. And nausea, headache, and fatigue, you'll see repeated over and over again. These are the most commonly reported side effects. Of course, these are not placebo, this is not a placebo-controlled trial, so they didn't simultaneously ask people who are taking nothing, do you have nausea, headache, and fatigue? And actually, a lot of people I saw anecdotally said they felt better once they started taking medications. Rash develops in about 6% or so of people, and that's primarily due to Semipravir more than sofosbuvir. But overall, it's exceedingly rare, and I think in the Semipravir, sofosbuvir studies, and most of these studies, it's exceedingly rare for anyone to stop treatment due to side effects. So this is a dramatic change from the interferon ribavirin era. So drug-drug interactions, I mentioned that this is one of the key parts, and I'll highlight here. So for Semipravir, calcium channel blockers, St. John's wort, statins, and azoles like fluconazole, ketoconazole, itraconazole, particularly our HIV patients may be on fluconazole. These are the drugs that interact most commonly. And you'll see over and over again, I say St. John's wort, statins, and anticonvulsants actually interact with almost all of these regimens. In terms of antiretroviral therapy, and I put the antiretroviral agents in a box on the right for all of these slides. The NNRTIs and PIs interact, etravirine, efavirenz, and ritonavir and cobicistat. So that pretty much knocks out all the protease inhibitors as well as Stribild or Genvoya. So certainly there are some drug interactions to consider with this regimen. So sofosbuvir actually has very few interactions, anticonvulsants, rifampin, and St. John's wort. So it's important, I realize with inmates, they may not be taking herbals and supplements, but for our outpatients and free world patients, certainly asking about herbals and supplements and making sure that they notify us if they decide to start taking anything is important. And antiretrovirals, very little in the way of interactions. Dupranavir, which I don't see anyone using, is really the only key antiretroviral interaction. So next came long Harvoni or Harvoni, sofosbuvir ledipasvir, 1 pill once a day, fixed dose combination, taken with or without food, $31,000 for a 4-week supply. So, compared to $150,000, this is only $90,000 for a 12-week supply. So it was an improvement. And it was very effective. So if we look at a 12-week supply of sofosbuvir or 12 weeks of sofosbuvir ledipasvir, 99% SVR rates. So almost everybody cured. And I think that that 1% really was someone who didn't follow up in clinic, not someone who actually relapsed. And actually later studies showed that 8 weeks was sufficient for people who had hepatitis C viral loads under 6 million. So now you're cutting the cost down to $60-something thousand. So it's gradually getting a little more affordable. And similar rates were achieved with treatment-naive cirrhotics with 12 weeks of treatment. So again, we could treat cirrhotics effectively, efficiently, and fairly quickly with just 12 weeks of treatment. So adverse effects, we have headache, fatigue, nausea, and some weakness and myalgia as well with the sofosbuvir ledipasvir combination. But again, very well tolerated, no discontinuation for side effects. The main drug interactions are similar to with the sofosbuvir alone regimen, the St. John's wort, the anticonvulsants, rosuvastatin. But acid-reducing agents has been a big limitation with Ledipasvir. Essentially, it requires an acidic environment for the drug to be absorbed. So people who are on proton pump inhibitors, and we see a lot of people on proton pump inhibitors, actually need to either decrease their dose of omeprazole to 20 milligrams, they can get away with that, or potentially stop it. Now, there's some recent data that are calling this interaction into question, so it may be that we can actually just ignore this current interaction because people prospectively studied seem to do just as well. But it's still something that gives us pause, and I'm not quite ready to treat everybody on proton pump inhibitors without trying to make some kind of adjustments. So the other key drug interaction with Ledipasvir is tenofovir, and Ledipasvir increases the concentrations of tenofovir, specifically TDF, so the tenofovir diproxidil fumarate. So this is, what's in Truvada and so forth, the older version of tenofovir. And essentially, the concentrations can increase, and that raises concern for developing renal insufficiency in people on tenofovir. This does not seem to be a concern with the newer tenofovir, the tenofovir alafenamide, that people are starting to use, although I don't know if that's made it onto TDC formulary yet. So the Vicura pack, this is the Ombidisvir, Paritaprevir, Ritonavir, Distabivir, and Ribavirin combination. So a mouthful. This actually, it's a combination pill that's once daily and a second pill that's twice daily with food, and then ribavirin also, which has to be split into twice daily. So it's a twice daily regimen with a total of about 5 pills. So significantly higher pill burden, more frequent dosing than the other regimens. AbbVie, who makes this, was a little bit not sure how they were going to get their market share because this was approved actually after Harvoni and Sofosbuvir, and so how are they going to recoup the costs when this is so much more difficult? And they were able to make agreements with some insurance companies and Express Scripts, Medicaid, in order to get on as the primary drug on formulary, and they've maintained their market share that way. You can see the cost is fairly similar. It's $28,000 for 4 weeks, so thinking $84,000 or so maybe for a 12-week supply. And ribavirin is relatively cheap, but has to be weight adjusted. So this is a very effective regimen with ribavirin, 97% cure rate, success rate with genotype 1A, 99% with genotype 1B. So very, very successful regimen as well, despite the higher pill burden and need for more frequent dosing and perhaps the concern about adherence. But unfortunately, ribavirin is necessary, and I'll get into the issues with that in a minute. This is also evaluated in people with cirrhosis, and it turns out that for cirrhosis, longer treatment is needed, 24 weeks compared to 12 weeks, and success rates were 94% to 100%. So still very successful, but when you're looking at 5 pills split twice a day for 24 weeks versus 1 pill once a day for 12 weeks, patients might feel stronger about the 1 pill once a day for 12 weeks. So one issue that's come up with this Vicura pack is this black box warning that came out in October. Essentially, they noticed in the post-marketing surveillance that people with Child's Class B or C, so not just asymptomatic cirrhosis, but starting to become more symptomatic and cirrhotics, had an increased risk of hepatic decompensation after starting Vicura. And so it was recommended then not to use Vicura for people with Child's Class B and C, and generally speaking, particularly for anyone with cirrhosis, to monitor the liver enzymes every 1 to 2 weeks for the first 4 weeks to make sure that people didn't go into hepatic decompensation, and also to educate patients about signs of hepatic decompensation such as jaundice, weakness, fatigue, altered mental status, increasing abdominal growth, and so forth. The side effects overall, headache, fatigue, nausea, similar to many of the other drugs. This more commonly caused a rash than some of the other regimens, and anemia attributed to the ribavirin is also a side effect of this regimen. So it's not as well tolerated as, say, the Harvoni regimen or sofosbuvir, samipravir. There are also some contraindicated medications with this combination. Most notably, combined oral contraceptives are contraindicated, which could be a major issue for people who are, want to use birth control, particularly on ribavirin. Statins and efavirenz are also contraindicated with this regimen. And then this is just strictly speaking contraindicated medications. Now, drugs in which there are drug interactions that may require adjustments or contemplating not using together also include some of the steroid inhalers, fluticasone, salmeterol inhalers, other statins as well, and omeprazole. So you can see, just like with some of the other regimens, the NNRTIs and the protease inhibitors do interact. And the other interesting thing I'd mention is that this contains ritonavir, and I think I have this in a later slide, but ritonavir does have anti-HIV effects. And so for someone who's not on antiretroviral therapy who has HIV infection, they would effectively be on ritonavir monotherapy. And so it's not recommended for HIV-infected people who are not otherwise on treatment. So must have the ribavirin later. Okay, so sofosbuvir decladisvir. This is recommended fairly recently. The sofosbuvir, again, we know about the decladisvir is relatively easy to take. It's once a day with or without food. And the interesting thing about decladisvir is it comes, essentially there are 3 recommended dosing based on what other drugs people are taking. The standard dosing is 60 milligrams a day, but if they're taking drugs that inhibit some of the hepatic metabolism, the CYP3A4 pathway, then it's recommended that they go to a lower dose. If they're taking medications that actually increase hepatic metabolism of drugs, then they go to a higher dose. And again, the regimen here, it's $49,000 for a 4-week supply combined, so $150,000 or so for 12 weeks. But again, 12 weeks, very effective. Here is the decladisvir sofosbuvir, 12 weeks, 100% sustained virologic response. So highly effective treatment for, this is for previously untreated people, and 24 weeks is recommended actually for previously treated people with hepatitis C infection. So very well tolerated. Headache, fatigue, nausea, you see a theme, are the most common side effects. Overall, maybe some people have some diarrhea too, but people do really well with this regimen as well. Now, the drug interactions are so contraindicated: anticonvulsants, St. John's wort, or rifampin. So again, thinking about the herbals, statins can also interact, but overall, the dose can be adjusted of decladisvir for most other medications that people are on. So whether they're on fluconazole for thrush, for NNRTIs, you can increase the decabovir dose to 90 milligrams. For protease inhibitors, you can decrease the decabovir dose to 30 milligrams. They're on cobicistat, like if they're on Stribild, for example, you can decrease the dose to 30 milligrams. So it's easy. It's a good regimen for people who are on these HIV regimens, antiretroviral regimens, who don't want to change their HIV meds or who have limited options for changing. So elbasvir grazoprevir is the least expensive. This was most recently approved maybe 2 months ago or so. So this is only $18,000 for 4 weeks, so $54,000 for a 12-week supply, gradually coming down in cost. And this was pretty effective. For genotype 1b, 99% sustained virologic response rate. The overall response rate for genotype 1a was a little lower, and it turns out, I mentioned earlier, that people can acquire hepatitis C, or the virus can, at the time of starting treatment, have resistance mutations. They're called resistance-associated variants in the hepatitis C world, or RAVs for short. So people without these RAVs that confer resistance to elbasvir actually have a very high sustained virologic response rate. And you can see that the failures are really the people who are resistant to the drug. So that makes good sense. Side effects: fatigue, headache, nausea. Makes it easy to explain to your patients what to expect. But some other kind of general side effects, but overall you can see the rates are 2%, 1% for most other symptoms. So again, a very, very well tolerated regimen. Contraindicated, St. John's wort, and convulsants, rifampin. So same drugs, primarily because of their effects on the liver, and other interactions as well with the statins. Like most of these other drugs, NNRTIs, particularly efavirenz and etravirine, are going to interact, and most of the protease inhibitors, primarily, especially with ritonavir, cobicistat, are going to interact with this regimen. So again, it's something to consider in our HIV patients. This may be a harder regimen for some of them. So genotype 4, there aren't as many regimens available for genotype 4 as genotype 1, and I don't think we've seen any genotype 4s here yet, but it falls in the less than 1%. I'm looking at my study coordinator, she's like, no. Falls in the less than 1% category, but generally speaking, it's 12 weeks, and it's similar regimens, the Harvoni or sofosbuvir, ledipasvir, grazoprevir, elbasvir regimen, as well as a variant of Viekira called Technivi. And Technivi essentially is once a day, so it's that combo pill that was in Viekira, the bidosvir, partaprevir, ritonavir combo pill without that disabovir that's twice a day. So this is once daily with food, $25,000 for 4-week supply, so $75,000 for a 12-week supply, and so similar cost, but at least this is a once daily regimen. And overall, sustained virologic response rates, again, in the 95 to 100% range. Very effective medications, whether using the sofosbuvir, ledipasvir, or this Technivi pack. Now, the Technivi pack, it doesn't really requires ribavirin, whether they're naive or treatment experienced, and so that's one limitation of the combination. Side effects, fatigue, nausea, weakness, headache, a little less common with this one, but still they can develop some allergic skin reactions like with the Viekira pack. Contraindications, again, got that oral contraceptive contraindication, lovastatin, simvastatin, and efavirenz are contraindicated. And then much like with the Viekira pack, similar other interactions, fluticasone, salmeterol, and the NNRTI and protease inhibitor interactions. So elbasvir and grazoprevir is also approved for genotype 4, and you can see here 12 weeks, 100% SVR rate. Doesn't really matter, in contrast to the genotype 1A where there are resistance mutations or the RAVs. This doesn't matter for the genotype 4. Resistance doesn't seem to occur, at least at this point, so it was very successful. And then I'll just talk here, the genotype, so genotype 2. So that was the big, broad overview of genotypes 1 and 4. Genotypes 2 and 3 now, so there are fewer regimens available. The one that's probably been used most recently has been sofosbuvir ribavirin for 12 weeks. And what's currently recommended is sofosbuvir decladisvir combination for ribavirin ineligible people according to the guidelines. And for genotype 2, no cirrhosis, genotype 3, no cirrhosis, 12 weeks is what's recommended. Extending treatment to 24 weeks is what's recommended with cirrhosis. So again, much like genotypes 1 and 4, longer treatment is needed for our cirrhotic patients. So the success for genotype 2 was great with the sofosbuvir ribavirin 12 weeks, but disappointing for genotype 3. So this is with the original PEG interferon ribavirin combination, and you can see 97% success with sofosbuvir ribavirin. But with genotype 3, it was really 56%. I was really disappointed after all of these studies of genotype 1 and genotype 4, 95, 100% success rate. People got used to seeing these numbers, and then all of a sudden there's a study with just 60%, and that was not good. The drugs, though, were pretty well tolerated: fatigue, some itching, nausea, and anemia, and that's associated with the with the ribavirin. And specifically, that's the slide I was looking for. I thought I put it earlier. So ribavirin also has a black box warning on it, and there are two reasons. One is ribavirin can cause hemolytic anemia. And this hemolytic anemia is particularly dangerous for people who have cardiovascular disease and can lead to non-fatal and fatal cardiovascular attacks, myocardial infarctions. So black box warning using ribavirin for anyone who has cardiovascular disease. So you can imagine that when sofosbuvir ribavirin was the only regimen available, interferon-free regimen available for our genotypes 2 and 3, what do we we're kind of stumped as to what to do with our cardiovascular disease patients. You just kind of have to wait. The other issue is that it's teratogenic, so or embryocidal. So for women, obviously you don't want to use ribavirin in pregnancy, and it's actually recommended not to have not one but 2 forms of contraceptives, not only for women, but for women who are having sex with men who are taking ribavirin. So very, very teratogenic, very bad. And if you think of like that, the Technivi or the Vicura combination in which oral contraceptives are bad, that just makes things, are contraindicated, that just makes things much more complicated. But so along came declitosphere and sofosbuvir combination for genotype 3. And thankfully, we finally, and at least in the non-cirrhotics, have a successful sustained virologic response rate with a drug regimen that is not teratogenic, will be nice to the baby, no concerns for teratogenicity. It was not as successful for cirrhotics, still about a 60% SVR rate. It turns out, though, extending treatment for 24 weeks did achieve 90-ish% success rate for the cirrhotics. So genotype 3 still remains one of the harder genotypes to treat, but there is at least now this combination. So genotypes 5 and 6, I won't talk too much about. We haven't seen any here. It's exceedingly rare. It's mainly seen abroad, but there are 12-week regimens available for them as well. So I want to focus a little bit more specifically on some of the Hep C HIV co-infected concerns. What's great is, in contrast to that 80% failure rates in the HIV-infected genotype 1 patients that we saw in the interferon ribavirin era, now we're seeing the same exact responses with the same regimens in our HIV-infected people. So we can get, we can cure 95+% of HIV-infected hepatitis C co-infected people with the same exact regimens. Drug interactions, I highlighted throughout, the NNRTIs and the PIs are really what we focus on, but declitosphere and sofosbuvir, as I mentioned, with the dose adjustment with declitosphere, really we can use this regimen with just about any antiretroviral regimen. And then I mentioned the ritonavir risk for developing resistance developing HIV resistance if people are not on antiretrovirals. That being said, I tend to favor treating everyone with HIV first before starting hepatitis C treatment because, one, I think everyone with HIV should be treated, and if they're not being treated, it's generally because they're too sick or they're not ready to commit to taking a medication every day. And if they're not ready to commit to taking their antiretrovirals, then I'm not sure they're ready to commit to taking the hepatitis C medication. But that's my own bias. So to demonstrate the success rate here of some of the common regimens, the sofosbuvir, ledipasvir, the Harvini regimen, 96% success rate in co-infected patients. The sofosbuvir declitosphere regimen, 96% in co-infected patients. This grisaprevir, elbasvir, 96% sustained virologic response rate. So excellent response rates. In these 2 studies, there were no issues with HIV rebound or blips or CD4 count changes. There were 2 blips in this grisaprevir, elbasvir study, but people subsequently resuppressed. So I think that's something that doesn't give me too much pause at this point. That was 2 out of 218. Who knows about adherence and so forth, but something to certainly keep in mind. So if we wanted to just pick a regimen for change our antiretrovirals to make it easy and give us the broadest option list for hepatitis C treatment, the easiest regimens are to have integrase inhibitor-based regimens. So both raltegravir and dolutegravir are good. They don't interact with any of the FDA-approved treatments for hepatitis C. Abacavir, lamivudine, and tenofovir, emtricitabine, generally speaking, are fine with most of the regimens, with the exception of ledipasvir and TDF interaction, where ledipasvir may increase the tenofovir concentrations. That being said, with Descovy, the tenofovir alafenamide formulation, that doesn't seem to be an issue. So people who are on, say, Descovy-containing regimens would be fine. So generally speaking, when I've been back in the early days when we were starting to treat our co-infected patients, I would put everyone on essentially either pretty much on an abacavir, lamivudine, dolutegravir regimen, just because it's simple. It's one pill once a day. Occasionally, if I wasn't planning on using Harvoni, I'd do the tenofovir, emtricitabine, dolutegravir regimen. Certainly, raltegravir is also easy to use. But now we have more options, especially with the destabavir because of, or decladisvir, sorry, which is right here in the middle there. There. We have more options there because of the ability to dose adjust. So renal impairment was another issue, and this was particularly problematic for some of our end-stage renal disease patients. So people who have chronic kidney disease, their creatinine clearance is still above 30. Overall, all of the regimens were fine. You had to dose adjust the ribavirin, but otherwise not a problem. People who have slightly lower creatinine clearance, so not quite end-stage renal disease needing dialysis, but certainly getting there. Overall, it was okay for the Vicura or Technivi pack, but sofosbuvir wasn't recommended for creatinine clearances under 30. So that really knocked out a lot of the regimens that we were using. And certainly among hemodialysis patients, we didn't have anything until a couple of months ago when grazoprevir elbasvir was approved. And actually, this regimen doesn't require any dose adjustment for any level of kidney function. We can use it in dialysis patients. And so that really, since being a dialysis patient is one of the risk factors for hepatitis C, it's going to be particularly useful for that population. So drug interactions, I mentioned, again, the contraindication with the oral contraceptives, St. John's wort statins, anticonvulsants are generally speaking interact with most of the regimens, and the acid-reducing agents with ledipasvir is one of the other key issues. Now the PDE5 inhibitor, so essentially sildenafil, Viagra, the interaction with this isn't a major issue if using these drugs for intermittent sexual activity, but it's really when people are using these drugs for pulmonary hypertension and taking it 3 times a day, that's when there's a drug interaction. And overall, most of the other drugs you probably don't see too many people on. So in terms of monitoring, frequent follow-up visits in clinic, phone calls, I usually like to see people about 4 weeks after starting treatment to see what their viral load is, see what their liver enzymes are doing. Almost always, people's liver enzymes have normalized by 4 weeks, and people have undetectable hepatitis C RNA levels really fast. It's amazing. It's super exciting, and people get excited when I show them that their liver enzymes are normal for the first time in decades. It reinforces the hard work that they've been doing in taking the medication and so forth. And for people taking ribavirin, depending on where their hemoglobin is starting, if their hemoglobin is starting fine in the normal range, I might wait 2 weeks to check their CBC. After about a week, in people who are starting off anemic, I might check their hemoglobin. So to summarize, hepatitis C is underdiagnosed, particularly among people who were born in 1945 to 1965. They're now well-tolerated, very efficacious treatments available that are effective even in HIV-infected people. Drug interactions and costs are really the major limitations we run into and the major considerations. And hopefully, as more competition comes into the market and as more patient demand, and unfortunately it sounds like as more lawsuits come up, the drugs will be more widely available. So I'm happy to take questions. Yes, Mercy. Mm-hmm. Harvoni is, I believe, about $94,000 for a 12-week supply. So to the patient, so some patients certainly have copay. So I should mention that a lot of the pharmaceutical companies do have patient assistance programs, and there are copay assistance programs as well. So some insurance plans have 20% out of pocket or 30% out of pocket. So you can imagine if 20% out of pocket of $30,000 is what, $6,000 a month for 3 months. I mean, that's still a pretty hefty price tag. So there are some patient assistance programs. The patient assistance programs are really helpful for people who don't have insurance. The issue, of course, is people who don't have insurance need to have access to see a doctor and get the lab work needed. Most of the patient assistance programs thus far with a lot of the drug companies don't cover people who have insurance, whose insurance has denied them coverage, which is unfortunate. Any other questions? Do we have any questions from the sites?
We only did it once. Yeah.
Was there a question? Yeah. Well, I hope so. What's that? It will? We can post it, Dr. Kaiser says. Good. Thank you. Okay. Great. Well, thank you all for your attention.